I'm Angela Hassiotis, and I'm Professor of Psychiatry of Intellectual Disability or Learning Disability at UCL, the Division of Psychiatry. So I have a role in terms of teaching and carrying out research. And also I'm a consultant psychiatrist, so I work in the NHS and I work in the Camden Learning Disability Service as a consultant psychiatrist. So I see and manage and treat patients with intellectual disability across the spectrum of intellectual disability, and they may have a mental health problem. Some of them obviously will have challenging behavior. I advocate on their behalf. I may carry out research within the service. I take part in service developments and so on. So that's my kind of general role. Obviously, we also train young doctors who specialize or want to specialize in the psychiatry of intellectual disability in the future. So I'm consultant, I'm a clinician, I'm an educator, and I'm also a researcher, and my basic interest in research is about health services and how we improve those services and how we evaluate interventions specifically for people with intellectual disabilities. So my service is for adults, but we do see sometimes younger people kind of age 16 and over, because of course there is a kind of transition issue there. So we may work together with colleagues from CAM special needs as child and adolescent mental health services, or we may assess individuals who are in inpatient services out of area and so on. Actually, how PBS can be something different than just an initiative. It seems to me PBS actually it's not a new initiative. It's been there for a long time. It's an intervention. It's almost a continuation of applied behavior analysis, or an advancement, or a kind of another format, I guess, which has now a kind of different set of principles embedded in terms of actually looking at people's environments and how the environment actually can trigger or maintain challenging behavior. So trying to get away from the very sort of specific behavioral element of applied behavior analysis. There are lots of arguments and debates about that, and I don't want to get into this particular discussion. However, in terms of actually distinguishing PBS from other initiatives, it's actually, and I would say the same for applied behavior analysis, although I think that the autism field has made more of a success in that for applied behavior analysis. But for PBS, I think that we should try and prove that it works, or which elements of it work best to help individuals to reduce challenging behavior. If we don't do that, and I'm coming at this from a very specific sort of lens, which is the research perspective, I think it's going to be another initiative. But if we wish to avoid that, then we need to really prove that it's the best thing that we can do for patients. If it's another intervention, if it's evidence-based, then it goes away from the realm of initiatives and it becomes something that we have to implement. We have to give this intervention to people because that's how we're going to make a difference in their lives. And there is no point, say, a service, for example, if we prove that this is the sort of best thing that we can do, or is better than doing nothing. Because this is the other thing. I mean, services in the UK in particular are probably at a more advanced stage than services elsewhere in the world, because we've got a specialism that's intellectual disability. So it may well be that whatever our practice is, I mean, that could be a potential outcome for us, particularly for the study, that whatever happens in normal practice, in routine care, is probably as good as. But what we have to understand is that we need to find the evidence. And it may not be everything about PBS, but it could be a specific component, say it's function and analysis, or something about the reinforcers and so on. But if we do, and if we prove that point, I think it will not be an initiative. It will be, more sustained sort of effort. It's something that we've got to do. So now the issue about the institutionalization, it's an interesting one because it has happened for many years, although there are still over 2,000 people in hospital and so on, although I guess the circumstances are different than, say, in the 60s and the 50s and so on. But there has been a lot of information about how people should be resettled in their local communities. There have been endless reports, there have been endless papers, scientific papers on, for example, specialist teams. They used to call them, and actually I think some colleagues still call them peripatetic teams. I would potentially call them specialist behavioral teams and so on. So we know about what we need to do, but for some reason we do not do those things. So I don't know whether it's an issue of implementation. I'm not quite sure whether it's the fact that the people with intellectual disabilities are under the social care agenda, and for whatever reason that prevents the mental health aspects or psychological or emotional aspects, including the challenging behavior and so on, to be recognized as particular elements that have to be taken out of that context. I mean, I work in an integrated team, so maybe that's the first thing. Maybe if all services were integrated, potentially we could have a better way of pulling budgets or managing someone who needs to be resettled, and managing the process rather of someone's resettlement. But we always sort of seem to have a difficulty, and given that we have not actually as yet compared different service models, so for example where a team is out there on their own as a tertiary service, for instance, or whether they're embedded or some other combination, if we don't have this comparative result, if we just have descriptions, that's not going to help us. But we have an idea of what might work, but without again showing how it works in comparison to something else, then I think we will still continue to struggle. And of course, there will be always other priorities. People with learning disabilities are about 1% of the population. If we think about mental illness such as psychosis, that's 1% of the population. And there's so much input for people with psychosis, although I'm sure they will say that there isn't enough. But what about our population? If it's 1% who also have, that they've got other difficulties and so on, then why is it that we're not doing something a bit more specific, a bit more concentrated? Why is it that we are still not able to put whatever evidence we have into practice, or carry out the kind of work that's required in order to be able at least to answer some of those questions? But the lessons have been there, and it's incredible to see that the first Mansell report was in 1993, that the first peripatetic teams were back in the 80s, and we're still struggling with those terms. Out of 154 areas in England in particular which have community intellectual disability teams, it's only probably about half of them or less, or fewer, who have specialist teams in some kind of format or another. Why is it? And again, goes back to the question of the government initiative. So maybe if there was a directive, that would help things to move along a little bit.